Hello and welcome back to another episode of the Oncology Brothers podcast. I'm Rohit Gosain, here with my brother and co-host Rahul Gosain. Today, we are excited to discuss yet another new FDA approval in the world of non-small cell lung cancer, Datopotamab deruxtecan, Dato-DXd, for previously treated EGFR-mutated non-small cell lung cancer. Dato-DXd was approved shortly after ASCO 2025 on June 23rd of this year, based off of TROPION Lung trials. To appreciate the nuances around this drug and the approval, we are joined by Dr. Jacob Sands, a thoracic medical oncologist from the Dana-Farber Cancer Institute, who actively participated in these TROPION lung cancer trials. Jacob, thanks so much for joining us today.
I've been excited about this. Thanks for having me.
Jacob, welcome, and congratulations for being part of the study, as now our patients have few more options with EGFR-mutated disease. Even before we touch on Dato-DXd, to set the stage, I think it's important to acknowledge that upfront for common sensitizing EGFR mutations, our options today are osimertinib with chemotherapy, and Amilas. Whereas for EGFR exon 20, in first-line settings based off overall survival, we have amivantamab with chemotherapy. And today, these patients are doing well in frontline, but we have limited options once the disease has progressed. And at that time, we're often looking for that resistant mutation or small cell lung clone, and then we're just cycling through our leftover chemotherapies. But now we have Dato-DXd based off TROPION Lung 01 and Lung 05. These trials included all EGFR-mutated disease. About roughly 85% was common sensitizing EGFR mutations. A very small subset was exon 20, and the rest was all other EGFR mutations. So this approval, again, is regardless of the type of EGFR mutation you have. Jacob, can you briefly touch on the mechanism of Dato-DXd and then walk us through the study design here?
Yeah, Dato-DXd is an antibody-drug conjugate. So it's an antibody to TROP2, which means that it binds to the TROP2 receptor on the tumor cells. And that then results in the compound getting internalized. And when it's internalized, that linker releases the payload. In this case, the payload is a topoisomerase inhibitor payload. Now, that payload also is membrane permeable, meaning that when it kills that initial tumor cell, it spills that payload into surrounding tissues and can cross membranes of surrounding cells as well. In that sense, not every cell has to be expressing TROP2, but if we have a real prevalence of TROP2 within the tumor environment, it's going to really selectively deliver that payload to that tumor environment. Now, within the two trials that you've highlighted here, these were brought together as part of an ESMO Asia presentation and pending publication. But TROPION Lung 01 was a randomized trial, Dato-DXd versus docetaxel. Now, this included all of non-small cell lung cancer. So it included squamous. Now, the squamous cohort actually looked worse than docetaxel. It included non-squamous non-small cell lung cancer with and without actionable genomic alterations as well. The tumors without actionable genomic alterations had to have gotten first-line platinum etoposide as well as checkpoint inhibitor, either concurrent or sequential. They could have gotten checkpoint first and then chemo, but had to have had both of those. In the tumors with actionable genomic alterations, they had to have received at least one line of prior targeted therapy, one or two, and then also get at least platinum-based therapy plus minus checkpoint, because in some of these we don't use checkpoint as much, so it wasn't ironed. So in that's kind of the broad for TROPION Lung 01. TROPION Lung 05 is essentially the same eligibility as those with actionable genomic alterations in TROPION Lung 01. It was a single-arm study. Patients had to have received at least one prior line of targeted therapy and also platinum-based therapy to be eligible for that study. Now, this is a combined TROPION Lung 01 and 05 in just those patients with EGFR mutation positive non-small cell lung cancer.
Thanks so much for going over the study design. ADCs are definitely changing the landscape. They've already done that in breast cancer space, but now doing in lung cancer space as well. This is the first TROP2 antibody-drug conjugate to get approved in lung cancer space. Jacob, this study looked at 117 patients in total. What did the study show to get this drug approved?
Ultimately, it showed efficacy as well as tolerable toxicity. That's the take
Right.
home, but there's definitely nuances to discuss. First, let's talk about TROPION Lung 1 because that's the randomized trial. We saw in all comers a significant improvement in median progression-free survival. That being said, the squamous cohort appeared better for docetaxel, so I would not choose to use it in that space. The non-squamous, kind of all-comer non-squamous non-small cell, statistically significant improvement in median PFS and a median OS that was comparable to PFS, but the confidence interval crossed 1. It was about a 2.5-month improvement in median overall survival. In the trial, there were 17% of patients enrolled made up the cohort with actionable genomic alterations. And in that cohort, we saw a substantial separation in the medians. It really looks like in that population is where we saw the most benefit. When looking at the cohort with actionable genomic alterations, EGFR has made up most of that. And that also seems like the cohort that gets the most benefit of any of the actionable genomic alterations. When we pull that from 01, along with 05, which was a single arm study where we saw efficacy benefit relative to historical controls. We see a median progression-free survival of 5.8 months, a median overall survival of 15.6 months. Now, the balance in these is, of course, the toxicities. There are a few that are specific to address, which I'm sure we'll get into. But by and large, on TROPION Lung 01, there were fewer dose reductions and fewer drug discontinuations in the Dato-DXd cohort relative to docetaxel, which is just to say that from a toxicity standpoint, I think this stacks up well to docetaxel. There's room for improvement, of course, but in making these comparisons, it does seem like a step forward. So all of that together is to say, okay, we've seen this broad signal of efficacy and tolerability. From what we have thus far, it's the EGFR positive cohort where we really see that signal of greatest efficacy. And so that is now the first, I suspect there will be more, but the first approval from the FDA.
No, indeed, these are exciting times, but at least from the community standpoint, with this new drug, one has to get comfortable with the side effect profile.
Yes.
Recently, Dr. Balajas Homos published a review article around this. My understanding is that prophylactic measures make a world of a difference here. Jacob, could you please help us out with some clinical pearls here with this drug?
Well, I hope so. I think there's still more work to do to better understand that. Now, stomatitis is where we're hoping that prophylaxis will help. In this trial, we saw a number of patients that had stomatitis. Now, most of them grade 1, 2. There was more grade 1 than grade 2. And grade 1 is asymptomatic. These are patients where you see something in the mouth, they don't feel anything, they wouldn't know the difference. So not all of the stomatitis was what we picture as that problem. Now, that being said, grade 2 stomatitis that goes on for more than a day is pretty annoying for patients.
Yep.
This is something we absolutely need to address. And in trying to address that, implemented steroid mouth rinses. Now, those mouth rinses were implemented really on the tail end of TROPION Lung 01. So most of the patients in this study, meaning the data you're seeing from this, does not represent outcomes with steroid mouth rinses. Now, in the breast study, which had less stomatitis, this was implemented earlier in that trial. There were more patients in that study that ended up with these steroid mouth rinses. Is the lower numbers a reflection of better outcomes with the steroid mouth rinses or differences in populations? I think there's more to study there. But prophylactic steroid mouth rinses may help, and that is something being implemented. Also, ice chips at the time of infusion, maybe it will limit kind of first pass flow to the mucous membranes. There is some TROP2 expression there, and so this may just be drug, hitting the target but off tumor. I think the most easy thing and most important really is dental hygiene, soft toothbrush, avoiding some of the foods and substances that might be more irritating to mucous membranes. But if there's any issue with stomatitis, then I think it becomes important to first let the stomatitis resolve before giving the next dose. Ultimately, though, if patients, if it becomes too much, I would prefer to dose reduce rather than stop the drug because we see an efficacy signal at 4 mg per kg as well. Starting dose is 6 mg per kg. But if you need to drop a dose, then you drop it, and we see a signal there too.
Jacob, what about dry eyes? Another thing that we're running into. My understanding is this is also low grade, perhaps artificial tears. And can you also talk about ILD? Is there any signal of ILD? Because with T-DXd, another ADC, we have to worry about that, and mortality is associated there.
That's exactly right. Now, with the ocular surface toxicity, we don't yet really know the mechanism of it, but clinically it does seem like dry eyes. That's the way it appears clinically, but what's really going on, we don't entirely know yet. I think in my experience, a lot of times is kind of like what happens with pemetrexed. You know, you have someone on pemetrexed for a while, they get a little bit of eye irritation, and I have them use preservative-free lubricating eye drops. Usually that's fine. And that's been my experience with this too, that overwhelmingly, if people get this kind of eye irritation, using these eye drops is fine. The FDA approval does recommend setting up with an ophthalmology or optometry exam from baseline. Doesn't have to happen prior to starting treatment, but just, you know, that you put in a referral for that to happen. I do think it's good to establish more if something comes up down the line so that they can be evaluated and get a sense of what has changed. Like I said, I'm not in a rush. I wouldn't hold up someone starting treatment for something like that. If somebody starts having some irritation and there's nothing more concerning, like sudden vision changes or beefy red eye, as ophthalmologists say. I'm not aware of that happening on the drug, but if there's something like that going on, they need to see an ophthalmologist immediately. If it's just a little bit of eye irritation, I'd have them use lubricating eye drops and I put in a referral. And if it takes a month for them to see an ophthalmologist or optometrist, I think that's fine. You know, it's not an immediate rush. Now, interstitial lung disease is a complicated one. Now, in this cohort of the combined TROPION Lung 01 and 05, the EGFR positive cohort, we saw 4% interstitial lung disease and one patient with grade 3. Across all of these deruxtecan payload drugs, we have seen ILD and in some cases grade 5 ILD. So we need to take this very seriously. That's true for trastuzumab deruxtecan. This is real. And we need to consent patients to it and be aware of it. What I will advocate for is something that seems a little contradictory. We need to be watching for this and aware of it. But if you see something that may be ILD, consider all the other things it could be. And don't just reflexively be like, oh, drug ILD. It could be something else. This is a challenge because we're monitoring T lungs and CT chest all the time. And we see inflammatory findings that wax and wane on various treatments. Those obviously are not ILD all the time. So how to decipher something that may be a drug-related ILD versus something that's waxing and waning? Anything showing up on a scan asymptomatic is grade 1. Somebody has any symptoms, that's a grade 2. That could be a wide range of possibilities. In some cases, you have one inflammatory appearing finding in one of the lungs, and someone says they notice they're a little short of breath when they go up a flight of stairs. Well, that's grade 2. And, you know, I think I'm saying that because I think when we picture ILD, oftentimes people talk about it like both lungs are just full of findings and someone's short of breath sitting in a chair. In that case, yes, we need to evaluate this person. I mean, that's the kind of person involved pulmonology. Maybe you need a bronch. Like what else is possibly going on here? And someone who has one little inflammatory thing on their lung, we shouldn't rush to say, oh, that's a drug-related ILD, halt everything. There's an art to the science of this, as happens in oncology, right? We're going to have to sort out individually with each patient, okay, what does this represent? And should we continue drug at this moment? Should I pause it? Should I involve pulmonology? And really encourage people to engage that workup before reflexively saying it's drug-related. Some of them will be. I mean, you have, and that's why we look for it.
Indeed.
We'll learn more as we see bigger and bigger studies with Dato-DXd. This still is a little different than what we see with T-DXd, grade 1, grade 2, take a pause. Whereas here, we did not see any grade 4, grade 5 ILD with Dato-DXd, though small study. All right, Jacob, drugs approved. After this conversation, I'm feeling a little more comfortable in managing side effects. But the bigger question is, how are you sequencing this? We are eagerly waiting on FLAURA2 data with osimertinib and chemotherapy. If we see OS, a lot of us will likely use that. Thereafter, are you going to use amivantamab and chemotherapy? Are you going to use Dato-DXd? Or what about if you've used amylase upfront? How and when are you going to use Dato-DXd? How are you using it today in your practice?
That's the big dilemma. I feel like the big challenge and complexity in EGFR right now is not Dato-D related, but AMI related. It's encouraging. We've seen a couple different studies now that have showed what you can do to reduce the toxicities of AMI, and I feel better about that. That being said, OSI as a first line works really well for a subset of patients. Many
Yep.
years of a single drug, after I've monitored them for a while and know they're tolerating it well, they come in once every 3 months for labs and a scan, and in many cases, a high five. I call those high five visits, and that can go on for many years. So I will admit there's a part of me that's a bit reluctant letting go of OSI alone. And I do think that there are some patients where that still is a good option.
Absolutely.
Now, across AMI, LAS, or OSI chemo, until we have the FLORA2 data, we kind of don't know. So I think there are a lot of people holding their breath, really hoping for that outcome. And I'm one of those because I think carbo-pem OSI is currently still a pretty simple regimen to give. We drop
Yes.
the carbo after 4 doses, and then people do better. That being said, AMI is getting better and better tolerated. So my practice has been more OSI or OSI chemo. I enrolled to the Shedders trial. I'm kind of interested to see that data. We'll see what that data for FLORA2 shows. The real dilemma is if someone has ME-LAS, they get chemo. If someone has had OSI, then they get chemo and. But if
Yeah.
someone has had OSI chemo, there's a huge dilemma. If there's been a long disease control interval, they kind of stopped maintenance pemetrexed after 6 months because they don't want to keep coming in for it. And now it's 2 years later, then okay, maybe AMI chemo is a good next line option. The real question, and I'm not trying to sidestep, the real question though is where is that line where you don't give them AMI chemo because they just had chemo? And I don't know if there's like a real objective line there. For me, I think it depends a bit on the person, how they tolerated it. But if it's been less than a year, then that's a pretty short time frame, and I'm less inclined. But I think that's where the biggest challenge is. Now, once they've had OSI and chemo, and if you're not, then I've highlighted AMI chemo where that potentially fits in. But if not that, then Dato-DXd. I mean, I think Dato-DXd very clearly post targeted therapy and post chemotherapy. And the real dilemma is that scenario that I was just trying to highlight a bit more, and it's hard to really be broadly specific in recommendations on a population level.
Yeah.
Patient shared decision making is going to be the key.
And
That's
again, this
right.
is not black and white. This is a lot of gray area. Jacob, just before we close, this approval is for all EGFR mutated patients. How comfortable do you feel for those uncommon EGFR mutations when it was a smaller subset?
Well, I'd use it. I'm going to kind of speak more broadly now in something that's more forefront. At World Lung, we saw the biomarker of a normalized membrane ratio testing. Now, this is still very much experimental. I think we have to wait and see how this pans out. This will be part of an analysis within a Vanzar first-line study for non-small cell that transitioned to enrolling more in non-squamous. That was Dato plus durvalumab. Now that data will come out and we'll get a bit more of a look as to whether this normalized membrane ratio testing is valid and how useful it is. Within a retrospective look from the TROPION Lung 01 data, Marina Garasino presented this at World Lung last year. In the plenary, this was designed for non-squamous, non-AGA population, where we saw clear separation and progression-free survival with that biomarker positive versus negative in the Dato-DXd treatment. In docetaxel, normalized membrane ratio, biomarker positive or negative, completely overlap. Now that's important because it tells us it is not prognostic. And so it really appears to be predicting those that are going to benefit more from Dato-DXd. Now, it was specifically designed for non-squamous, non-AGA. We did see that biomarker positive rate kind of run by what we see in outcomes. So the actionable genomic alteration population had the highest NMR positive of all of them, and then non-squamous, non-AGA, and then squamous positive in 44%. And we previously also saw a neoadjuvant data set presented by Tina Casconi that included Dato-DXd, where there was a squamous group in that had a pretty impressive path CR rate. So I do think that there are individuals with even squamous where this works. I would not use it in that setting without further, I mean, to be very clear, I'm not advocating that it be used, but that this is an area for further study. So in that EGFR population, there may be more of an inclination that it is biomarker positive, meaning that we may have more internalization of a TROP2 receptor within that subset. So it's not necessarily driven by some specific form of that EGFR receptor like osimertinib or these other targeted therapies, but maybe more a correlate. So that's kind of a longer answer to say, I think within that EGFR cohort, I would really consider this for all of those.
And we don't have too many options here. So given that, this is what we're going to rely on.
That's exactly right. Docetaxel is the alternative, and it's obviously not a great one.
These are exciting times in the field of oncology, as almost every other week, if not weekly, we are seeing new drug approvals or indications where our patients are living longer and longer. Jacob, thank you for all the insights around this recent approval. For our listeners, let us go over a quick recap. In today's discussion with Dr. Jacob Sands from Dana-Farber, we had a chance to touch on the recent accelerated approval of Dato-DXd for EGFR-mutated non-small cell lung cancer that has progressed on anti-EGFR and platinum chemotherapy.
Well, the important point here is Dato-DXd approval is regardless of the type of EGFR mutation we see, and this is first TROP2 ADC to get approved in non-small cell lung cancer space.
Absolutely. During our discussion, we touched on the data, including the overall response rate of 45% and median duration of response being close to about 6.5 months.
And a few side effects to keep in mind with Dato-DXd are mucositis, nausea, fatigue, and dry eyes. Prophylactic measures such as steroid-based mouthwash and artificial tears can help with negating some of these common side effects. Thanks for joining us. Please make sure to check out our other discussions around FDA approvals, ToxCheck, and treatment algorithms. We are the Oncology Brothers.